I am Dr. Elnemr. This is the third lecture in hepatic surgery about the cystic hepatic lesions. Hepatic cystic lesions are classified into four broad categories. The congenital category includes simple bile duct cyst, polycystic liver disease. The infectious category includes pyogenic liver abscess, amoebic liver abscess, echinococcal cyst or hydatid cyst. The traumatic category includes liquefied hepatic hematoma and viloma. The neoplastic category is either benign or malignant. The benign group includes cystic cavernous hemangioma, hepatic lymphangioma, and biliary cyst adenoma. The malignant group includes primary malignant neoplasms, such as cystic hepatocellular carcinoma, other necrotic neoplasms, biliary cyst adenocarcinoma, and embryonal carcinoma. The secondary cystic malignant neoplasms, such as metastases from the pancreas and ovary, like mucinous cyst adenocarcinoma. Simple hepatic cysts or hepatic bile duct cysts. Simple hepatic cysts are benign developmental lesions, originate from hamartomatous tissue, more often discovered in females, almost asymptomatic, can be solitary or multiple. Typically, they are well defined with a rounded or ovoid shape. Typically, the cysts have three layers. The inner layer, which is loose in connective tissue rich in cellular element. The middle layer, which is poor in nuclei. The outer layers, which composed of segments of bile ducts, island of hepatocytes, and connective tissue blend into the liver parenchyma. As we see in this specimen, the simple cyst is a thin-walled cystic lesion with no evidence of complex internal features like septations or mural irregularity or nodularity. However, the cyst wall may show papillary tumors or communicate with the biliary tree. As regards the diagnosis, ultrasonography is sufficient to diagnose the simple hepatic cyst, and here we can see a well-circumscribed hypoechoic lesion. By using the contrast-enhanced spiral CT in the arterial face, the hepatic parenchyma enhances while the cyst not enhancing. Also on the portal face, the hepatic parenchyma enhancement increases and the cyst is still not enhanced. In the delayed phase, the hepatic parenchyma showing the washout while the cyst is still unenhanced. So the cyst does not enhance in any of the three phases because the cyst wall imperceptible to die. This example in the portal venous phase showing multiple homogeneous rounded or oval well-defined non-enhancing lesions. Treatment of solitary simple cyst. Both needle aspiration and catheter drainage are usually associated with recurrence. The ideal treatment is wide unroofing or deroofing, and this can be done by both open or laparoscopic approaches. Marsupialization is better to be done for infected cysts. Two important things should be searched for. The first is whether there is a communication between the cyst and the biliary tree or not. If there is a communication, it should be internally drained to Rho and Y cystogeneostomy. The second is whether there is a papillary tumor arising from the cyst wall or not. If papillary tumor is found, it should be excised. Hepatic formal resection can be done, but it is risky. This figure showing the unroofing. And this is the marsupialization done by suturing the edge of the unroofed cyst to prevent the closure. Polycystic liver disease. Polycystic liver disease is an autosomal dominant disease. About 75 to 90% of patients with autosomal dominant polycystic kidney disease have associated polycystic liver disease. Isolated polycystic liver disease is very, very rare. The pathophysiology is either malformation of hepatic ductal plate or abnormal cilia of cholangiocytes, which results in decrease in the cytoplasmic calcium and cyclic AMP, and this results in altered balance between the fluid secretion and absorption in the lumen of the biliary ducts. Polycystic liver disease is classified by Gigot into three types. Type 1, the number of cysts are less than 10, and the large cysts more than 10 centimeter in diameter. In type 2, there is diffuse involvement of the liver by multiple medium-sized cysts with remaining large areas of normal liver. In type 3, there is diffuse involvement of the liver by small and medium-sized cysts with only few areas of normal liver. This condition is usually asymptomatic. Uncommon symptoms include abdominal distension, early satiety, and orthopnea. Advanced disease can result in hepatomegaly and compression of surrounding structures and may lead to Budd-Chiari syndrome, inferior vena cava syndrome, compression of portal vein and bile ducts. Complications also can occur in the advanced disease and include infections, torsions, rupture, and hemorrhage. In other words, the symptoms includes two groups. The first group is the group of symptoms due to the mass effect, and the second group is the group of symptoms due to the complications of the cyst. The portal venous phase, in contrast, enhanced CT examination showing multiple non-enhancing hepatic and renal cysts. In the arterial phase of gadolinium enhanced T1 weighted image of MRI showing homogeneous and well-defined cysts in both the liver and the kidney, we can notice that there is no enhancement of either the wall or the contents. MR cholangiogram showing scattered numerous hyperintense cysts of variable size, and this cystic lesion don't communicate with the biliary tree. This specimen of hepatectomy showing multiple or numerous thin-walled cystic lesion, and this is a cut section. The management strategies based on Gigot classification are non-surgical approach and surgical approach. The non-surgical approach including medical treatment and interventional radiology. And the medical treatment, the somatostatin analogs and mammalian target of rapamycin inhibitors are used. As regards the somatostatin analogs, they are inhibitors of cyclic AMP and they reduce the secretions of fluids and proliferations of many cell types including cholangiocytes. They also suppress expression of many growth factors. The mammalian target of rapamycin inhibitors, they have anti-proliferative effect, but its efficacy is not proven yet. The interventional radiology is either by transcaster arterial embolization by microcoils or percutaneous radiologically guided aspiration of the cyst's content followed by injection of sclerosing agents as ethanolamine oleate or tetracycline. The surgical approach includes fenestrations or unroofing, hepatic resection with fenestration or liver transplantation. To point out the management strategies based on Gigot classification, in type 1, both percutaneous sclerotherapy and fenestration and roofing can be done. The two options are the best for superficial and limited number of large cysts. In type 2, hepatic resection or partial hepatectomy with fenestration of the remnant cyst if feasible. In type 2, liver transplantation is the solution. Caroli disease. It is an autosomal recessive disorder characterized by congenital communicating multifocal saccular dilatation of intrahepatic bile ducts. It is often associated with cystic renal disease, particularly medullary sponge kidney. Cholangiocarcinoma may develop in up to 7% of cases. There are two forms. The common form, it is associated with the portal fibrosis that may progress to portal hypertension and cirrhosis. The pure or simple form, which is rarer, it is associated with intrahepatic stones, cholangitis, and abscess formation. The portal venous phase of triphasic CT scanning showing saccular dilatation of the biliary tree, as you see here, with and central portal vein radical enhancement, and this is picture called central dot sign. Cholangiogram is used to delineate the dilated intrahepatic biliary tree. The treatment of choice is segmentectomy or hepatic lobectomy if the disease is confined to one segment or hepatic loop, respectively. For more diffuse disease, liver transplantation is the ideal treatment. Hydatid cysts or echinococcal cysts, they are caused by flatworms or cystoids, mainly Echinococcus granulosus. Others are Echinococcus multilocularius, Echinococcus bogelii, Echinococcus oligarthrus. These are the flat worms or the cystoids. The left one, which is Echinococcus granulosus, about 5 millimeter in length. This is the parasite. It consists of head named scolex, the head containing hooklets and suckers, which attached them to the mucosa of small intestine of the primary host, and then followed by segments. The segment next to the neck is called immature proglottid. The next is mature proglottid, at which contain both testis and uterus, and that's why this parasite is hermaphrodite. The last segments called the gravid proglottid, and they contain eggs. So each segment may contain as many as 40,000 eggs. The eggs contain an embryo with named hexacans embryo, and this is the structure of the mature hydatid cyst, will be discussed later. The adult parasite is about 5 millimeter long. It is hermaphrodite, as I said before. It infests the small intestine of carnivorous animals like dogs and foxes, which are the definitive host. Man is an accidental intermediate host. About 65 to 75% of the hydatid cysts occurs in the liver and 25% in lungs. About 5 to 10% affect other anatomical locations. The disease is common in cattle or sheep breeding countries. In the Middle East, it is common in Algeria, Libya, Sudan, Ethiopia, Yemen, Iraq, Iran, and Turkey. This is the life cycle of Echinococcus granulosus. The definitive host is the dog. The dog become infested by this parasite when eating or ingested the contaminated viscera of the sheep containing the mature cyst. In the intestine of the dog, the cyst get digested, releasing the scoleces. The scoleces attach themselves to the mucosa of the small intestine of the dog and then grow to form the adult worms. As I said before, the next or the last segments containing many eggs, and this eggs comes out with the feces of the dog and contaminate the grass and vegetables. When the sheep eating them, they get infected by release of the hexacans embryo from the egg, and this eggs transferred to the portal circulation and other site. Man is an intermediate host when eating a vegetable contaminated with the dog's feces containing the eggs with its hexacans embryo, and this is eggs hatched to release the hexacans embryo and have 6 hooklets. They attach themselves to the mucosa of small intestine. So the ingested eggs by human being release larvae into the duodenum. The larvae migrate through the intestinal mucosa, and larvae get access to the mesenteric vessel and to the liver. The larvae escape the host defense and persist in a host organ like the liver, and develop into small cysts surrounded by fibrous capsule. Cysts grow at a rate of 1 to 3 centimeters each year and remain undetected for years. And these cysts can reach a very large size before they become clinically evident. Pathology of the cyst. The liver is the commonest organ affected in about 75%. The right lobe is the commonest site of the liver. Cyst is usually single, very rarely become multiples, and consists of 3 layers. The inner layer which is called the endocyst, it is a germinal layer. Consists of flattened epithelium which proliferate to give rise to daughter cyst and or a broad capsule and scoliosis that hang in the cavity, which is filled with hydrated fluid secreted by the germinal layer. The middle layer, or the laminated membrane, or the chitinous layer, it is a protective layer of concentric laminae acting as a barrier prevent injurious substance as bile from reaching the cyst cavity. The outer layer, or the ectocyst, it is a fibrous layer belong to the host. It is a body reaction to the cyst. The older the cyst, the thicker this layer. It may be very thick in the liver and thinner in other organs like lung and brain. This photo shows the opened hydrated cyst with multiple daughter cysts. The condition is asymptomatic in 75%. However, symptoms appear in 25% in the form of dyspepsia or attacks of urticaria. Right upper quadrant pain, fever, and jaundice mean complications. Signs include right upper quadrant mass in 70%, right upper quadrant tenderness in 20%. The mass is tense, cystic swelling, moving up and down with respiration, not tender unless complicated. It is dull on percussion, and dullness is continuous with the liver dullness. Hydrated thrill felt on palpation due to the impaction of scoliosis against each others in the hydrated fluid. The laboratory findings may be eosinophilia in 35% and elevated bilirubin in 20%. The radiological diagnosis starts with brain X-ray, which show unilocular large calcified cyst with elevated right copula of diaphragm. However, in fluoroscopy, its movement will be markedly restricted. In 2017, the WHO proposed the hydrated cyst classification based on ultrasonographic features. Type 1 is a simple cyst. Type 2 is a multivesicular, multiseptated cyst. Type 3 cyst is a complex cyst with hydrated sand and floating membranes. It is a transitional stage, and the cyst is losing viability. In type 4, there is heterogeneous degenerative contents with scattered calcification. It is an inactive cyst. Type 5 is a densely calcified masses, and this is an inactive stage also. This slide shows two examples of type 2 cyst as they appear by ultrasonographic examination. The first one is a mother cyst containing three daughter vesicles with peripheral location, and the hydrated matrix with a solid appearance is seen filling the rest of the cavity. The second example shows the big mother cyst with many daughter cysts having the appearance of honeycomb or rosette-like structure. This slide shows CT scanning of the liver with type 2 hydrated cyst on the right, causing bulging of the liver capsule and predominant daughter cysts. The septi are the wall of the daughter cyst flattened by contact of the cysts with each other. Contrast enhanced abdominal CT examination showing large cystic lesions contains streaks of debris, and in the right picture, which is at the lower level, show what appears to be a cyst within a cyst. In the portal venous phase, we can see two cystic lesions with subtotally calcified wall. This is a contrast enhanced CT showing a round lesion with water attenuation and a large ring like pattern of calcification, and this represents a calcification of the pericyst. This is a simple viable type 1 cyst as it appears by MRI examination. This is a T1 weighted image. The cyst wall is iso intense relative to the cyst contents, which have a low signal intensity. In T2 weighted image, there is a high signal intensity of the cyst contents. This means fluid inside with a low signal of the wall. This is another example of T2 weighted MRI image showing a solitary hyper-intense region with hypo-intense pseudocapsule and internal calcifications at the arrowheads. Cholangiography may be needed in some cases because the cysts may communicate with the bile ducts. The hydrated cyst may communicate with the right hepatic duct in 55% of cases, with the left hepatic duct in 29%, and the common hepatic duct is 9%, with the gallbladder in 6%, with the common bile duct in 1%. In this ERCP film, we can see the connection between the right hepatic duct and the cyst. In MRCP, we can see the communication between the ruptured hydrated cyst and the biliary radical. In routine laboratory blood workup, the liver involvement may be reflected in many ways, like an elevated bilirubin, an elevated alkaline phosphatase level, leukocytosis, which suggests infection of the cyst, eosinophilia in 25 to 35%, hypogamma globulinemia in 30%. Serological diagnosis can be performed by many tests. The serum immunoelectrophoresis detects about 90% of the cases, but remain positive 1 year after eradication of the disease. Indirect heme agglutination test detects about 85% of cases and remain positive for many years. The complement fixation test remained positive for 6 months. The older intradermal test of Kazuni it is obsolete now because the results remain positive for life. Complications of hydrated cyst. Leakage of hydrated fluid leading to repeated attacks of anaphylaxis, which may lead to anaphylactic shock. Cracks in the laminated membrane with acetylite cysts around it. Rupture of the cyst into the biliary tract, leading to obstruction and jaundice, into the peritoneal cavity, leading to multiple hydrated cysts in the peritoneal cavity. Rupture into the bowel, it is a natural cure. Rupture in the lung and pleural cavity, leading to emphysema. Ruptured into the bloodstream, leading to fatal anaphylactic shock. Rupture in the renal pelvis, leading to hematuria and colic. Secondary infection leading to pyogenic liver abscess. Pressure on the surroundings like the liver, diaphragm, and vessels. Calcification and death of the cyst. And this is the natural cure and require no treatment. An example of direct transdiaphragmatic intrathoracic rupture. The rupture here usually is more to the lung and the bronchial tree rather to the pleural cavity because of the adhesion between the upper surface of the liver with the diaphragm, which is the bare area, and so the contents go directly from the cyst to the bronchial tree, and the patient can expectorate the contents. And this is an example of the communicating rupture. We can see here the intra-biliary rupture of the hydrated cyst, visualized as a dilated biliary system with intraluminal daughter vesicles and membranes in patient presented with jaundice. These are the sites of direct pressure and exophytic growth of the hydrated cyst and occur in two common sites. One of the posterior surface of the liver at the bare area, so the cyst content can penetrate the diaphragm directly, as I said before, and to communicate with the pleural, so the bronchial tree. And the second route is through the gastrohepatic and gastroduodenal ligament, and so the cyst may compress the portal vein, lead to portal hypertension and collateralization, as shown in this photograph. The treatment of hydrated disease is by medical treatment, which is anti-helminthic drugs. Second is by a pair technique. 3, surgery. 4, other procedures. The drugs used in medical treatment is mebendazole, albendazole, and praziquantel, which is anti-schistosomal drug. The regimens usually for 3 months. The first week of this regimen is by praziquantel, 50 milligram per kg, and continue for the 3 months by albendazole, 400 milligrams twice daily, and this usually precede surgery. And this medical treatment can continue for 1 year after surgery. The percutaneous treatment called PAIR technique, it is minimally invasive and used under ultrasonographic guidance. PAIR, P is puncture of the cyst, 2 aspiration, 3 injection, 4 re-aspiration again. After an aspiration of the cyst contents, sclerocidal agents are injected into the cyst cavity to inactivate the parasites, and many solutions used like silver nitrate 0.5%, citramide 5%, hypertonic saline from 15 to 20%, formalin 10%, absolute alcohol, and some people used bovidone iodine. The pair techniques must be used in a complete aseptic technique and using the pigtails, catheters, and syringes, and so on. Indications for pair technique according to the World Health Organization: cysts accessible to puncture, patient who refuse surgery, surgery is contraindicated, or relapses after surgery, or a pregnant woman, and children over 3 years, and failure to chemotherapy alone. The contraindications for pair technique are non-cooperative patients, inaccessible or risky location, inactive or calcified lesion, or cysts communicating with the biliary tree. So when we do the pair and during aspiration, if the bile come out, the procedure must be terminated. Surgical management remains the treatment of choice. The principles of hydrated surgery are to totally remove the infective components, avoidance of spillage of the cyst contents, management of communication between the cyst and the adjacent structures, management of residual cavity, minimize the risk of the operation. Types of hydrated surgery are four. Number one, cystectomy. This can be done by an open method. So this is a total cystectomy in which the germinal layer and the laminated membrane are removed after opening the pericyst. In total pericystectomy, the adjacent liver tissue also removed with the cysts. So the 3 layers are removed. The subtotal or partial cystectomy, here we can leave the cyst is removed and leaving some parts of the wall if they are adjacent to a major structure. The fourth line of treatment is anatomical resection. This is the open cystectomy in which the cyst is totally removed. The removed cyst include the laminated layer and germinal layer with the contents of the cyst, leaving the pericyst in place. In total pericystectomy, all layers of the cyst, I mean the 3 layers of the cyst, the ectocyst, the laminated membrane, and the endocyst, are removed together with some liver tissue around, and this is usually done for peripheral and superficial exophytic hydrated cysts. In subtotal pericystectomy started by aspiration of the contents, and the pericyst is dissected from the parenchyma and proceeding towards deeper planes. The deepest part of the pericyst in the parenchyma is left in place to prevent injury of intrahepatic vascular structures, and then cleaning the cavity with saline solution. Subtotal pericystectomy starts with the aspiration of the liquid content, followed by aspiration of the daughter cyst using a wide pore tube, and then dissection of the cyst wall from the parenchyma, and this leaving the deep part of the cyst wall adjacent to major vessels like IVC or right hepatic vein. Then sutures are placed in the edge of the remnant cyst wall like this. Then the interior edge is sutured and anchored in the posterior wall, and this is called cabotinage, something like this. The cabotinage is completed when the edges of the anterior cystic wall remnant are sutured in posterior wall, and this prevents the post-operative dead space, which facilitates fluid collection. Historically, a round surgical suction cone was used. It is a metal cryofunnel. Its lower end is put on the cyst wall, and liquid nitrogen passing from this tube, and this makes the lower end freeze and adhere to the cyst wall, preventing contamination of the surrounding structure, and cyst can be dealt with from the wide upper part. At the end, operative cholangiogram is done in cases of communication between the cyst and the biliary tree to ensure complete closure. Then ensure hemostasis, and then if spillage of the cyst contents occurs, wash with sterile water to reduce further infestations. Standard liver resection should be avoided or performed a la demande. Hepatectomy is extremely dangerous because risk of biliary and vascular injuries and alterations of intrahepatic anatomy, even the anatomy of Gleisonian structures by compression and inflammatory adhesions. Hepatic resection may be performed in the peripheral lesions like the entire segment 2 and 3, or localization of the hydrated cyst in segment 5 and 6. Other procedures that may be done in secondary infection: marsupialize the large cyst. In case of jaundice following intrabiliary rupture, open the common bile duct and clear the duct from the hydrated materials like small cysts or detached wall parts and debris, and insert the T-tube. In case of peritoneal rupture, clean the peritoneal cavity meticulously and do careful lavage. Hydrated cyst can be managed by laparoscopy. A special instrument has been developed called perforator grinder aspirator apparatus. The instrument penetrates the cyst, grinds the particulate matter, and sucks it all out. The advantage of this instrument is that it does not get blocked by the daughter cysts and laminated membrane. The exclusion criteria for laparoscopic management are rupture of the cyst in the biliary tract, central localization of the cyst, cyst dimension more than 15 centimeter, number of cysts is more than 3, and thickened or calcified walls. The endoscopic management may be done in cases of intrabiliary rupture or residual diseases after surgery left in the biliary tract, like hydrated materials, for example, membrane and daughter cysts. ERCP is the gold standard in confirming biliary tract involvement and may be of therapeutic benefit. Here we can see the dilated duct with debris and daughter cysts that appear as radiolucent film defect. Their irregular leaf-like material, which change in shape with pressure, is characteristic. Here we can see the hydrated material protruding from the ampulla of water, and this can be extracted, followed by clearance of common bile duct. Next, the biogenic liver abscess. The causative organisms in case of biogenic liver abscess are mostly polymicrobial, usually gram-negative. Most organisms are of bowel origin, like Escherichia coli, Klebsiella pneumonia, Bacteroides, Enterococci, anaerobic streptococci. In case of bacterial endocarditis or dental sepsis, Staphylococci, hemolytic streptococci, or Streptococcus milleri are the causative organisms. In immunocompromised patients, usually a fungal infection. Pathological conditions that may lead to biogenic liver abscess may be in the biliary tract, like gallstones, cholangiocarcinoma, or stricture, may be coming from the portal vein, as in case of appendicitis, diverticulitis, or Crohn's disease, or from direct extension from gallbladder emphysema or perforated duodenal ulcer or subphrenic abscess, or maybe come from the hepatic artery as in case of dental infection or bacterial endocarditis. Other conditions may be post-traumatic or iatrogenic or liver biopsy or blocked biliary stent or cryptogenic or secondary infected liver cyst. Features of biogenic liver abscess. Onset may be insidious or occult in elderly people. Patient may present with complaint of the primary source of infection. Anorexia and weight loss may be noted. Fever. Some patients have fever of unknown origin. It may be nocturnal fever with sweats. Usually there is right upper abdominal quadrant pain. Jaundice occur only in late stage unless there is suburative cholangitis. On examination, the liver is enlarged and tender. Percussion over the lower ribs aggravates the pain. Laboratory investigations showing leukocytosis, increased erythrocyte sedimentation rate, mild anemia, elevated alkaline phosphatase activity. The transaminases show marginal abnormalities and hypoalbuminemia. Plain X-ray chest shows abnormalities in about 50% of patients. Here we can see a soft tissue shadow with a contained gas inside it, and this shadow elevating the right copula of the diaphragm. There may be also signs of basal atelectasis and obliteration of the right costophrenic angle. If the cause is gas-forming organisms, the abdominal X-ray film may show evidence of intrahepatic air, portal venous gas, air fluid level, or air in the biliary tree. As in this picture, we can see the right copula of the diaphragm is highly elevated in comparison to the left copula, and the softish shadow show fluid level and gas inside it. Ultrasonography is a non-invasive tool and with no radiation hazards, but it is an operator dependent. It can only identify lesions more than 2 cm, and it is inferior to CT in locating the multiple small abscesses in the liver dome or in fatty liver. The abscess is seen as solitary and sometimes multiple, poorly demarcated, with fluid inside it, and round hypoechoic lesion within the hepatic parenchyma with surrounding edema and hyperemia. The CT is the most effective tool and can detect abscesses of 0.5 cm. Importantly, it can visualize the coexisting intra-abdominal pathology and delineate abscesses near the diaphragm or in fatty liver, and should be routine if diagnosis is considered. ERCP and BTC are reserved for patients whose data suggest biliary system as a source by ultrasonography and CT. In this slide, obtained from a delayed phase contrast enhanced CT examination, we can see a thick-walled cyst with peripheral edema and enhancement. Also, we can see a small pocket of air. In this slide, we can see a large multiloculated abscess with enhancement of the wall and septations, and we can see a pocket of air here and air fluid level in this site. The treatment of biogenic liver abscess usually is started by medical treatment in cases of multiple small abscesses, and these abscesses usually respond to antibiotics. Obstruction of bile duct must be excluded as a source of infection, and ERCP with stenting can be performed if necessary. Percutaneous aspiration can be done for abscesses less than 6 cm in diameter, but percutaneous catheter drainage should be used if the abscesses is more than 6 cm. These are the equipments used for percutaneous catheter drainage. It is a pigtail catheter. This is a percutaneous catheter drainage. We can see the pigtail catheter coming out from the patient abdominal wall and the syringe containing purulent pus, and this X-ray demonstrates that the pigtail catheter is correctly placed. Of course, the aspirate must be sent for culture and cytology. In this example, we can see a wide bore catheter like Malicot or de Bever catheter coming out from the abscess cavity. You can see the abscess cavity is collapsed with a minimal content and slight gas inside. However, the complications of percutaneous drainage are perforation of a viscus during the introduction of the catheter, pneumothorax, bleeding, and leak of pus into the abdomen. The indications for open surgical drainage are failure of percutaneous drainage, as sometimes a thick viscid pus cannot be drained in case of large abscesses, in cases of multiple abscesses or loculated abscesses, because the catheter drain only one loculus, in case of deep-seated abscesses not amenable for percutaneous drainage, or importantly, if there is coexisting intra-abdominal disease that require operative management. Open surgical drainage can be done by many approaches, like the posterior subpleural approach, or transpleural approach, or transperitoneal approach. And approach is preferred as intra-abdominal pathology can be dealt with. Laparoscopic approaches can be done also. This is an example of the open drainage after inciting the liver tissue above the abscess. A finger is introduced to break down the loculi and make it all one cavity, and this cavity is drained and washed, and the omentum can be placed to obliterate the abscess cavity. The complications of biogenic liver abscess are recurrence of abscess, widespread infection in the abdomen, overwhelming sepsis, rupture into adjacent organs and cavities, such as the pleura and lung, leading to pleural effusion, empyema, even bronchohepatic fistula, rupture into the abdominal cavity, leading to subphrenic abscess, subhepatic abscess. Even it may rupture into the hollow viscus like the stomach and colon. Also, rupture may occur into the pericardium, especially in case of left hepatic lobe abscess. Now, the amoebic liver abscess. The disease is common in areas of poor sanitation. The infective stage is the amoebic cyst and transmitted by fecal-oral route. When the human ingests the amoebic cyst in the intestine, it releases the trophozoite or the active parasite, and this parasite erode the mucosa of the intestine and travel through the mesenteric veins to the portal vein and to the liver, where it forms amoebic hepatitis followed by amoebic liver abscess. The trophozoite reach the liver by many routes, as a portal venous system, mesenteric lymph channels, or intraperitoneal spread. Within the liver, it forms microscopic sites of thrombosis and cytolysis and liquefaction, leading to amoebic hepatitis. And these foci coalesce together to form hepatic abscess. The inner wall of the abscess is ill-defined layer of necrotic liver tissue. This is called a shaggy wall. The abscess contains fluid, which is anchovy, like anchovy paste, or chocolate, which is reddish brown, because it is composed of liver tissue and red blood cells, may be green or yellow. It is sterile and odorless, and this is how it looks like the anchovy sauce or the chocolate. And the inflammatory cells are absent from the capsule. This is show how the amoebic liver abscess looks in a cadaveric liver. Uh, the abscess has a shaggy inner wall and containing fluid that has been described in the previous slide, and a connective tissue capsule. These are the very important characteristic of the amoebic liver abscess. It is often superficial, usually in the right lobe in more than 70%, and solitary in more than 85%, and vary in size from 1 centimeter up to 25 centimeter in diameter. The cysts grow by active necrosis and may rupture. Usually the patient complains of pain, low-grade fever, nausea and vomiting, anorexia, weight loss and malaise, diarrhea, cough and pleurisy, and pruritus. On examination, there is upper abdominal mass, hepatomegaly, or right upper quadrant tenderness, signs of pleural effusion, and jaundice. The lab investigations show in the stool analysis we may find the trophozoite or the active parasite and the amoebic cysts. The alkaline phosphatase show high activity. There is mild leukocytosis, low hemoglobin concentration, low albumin level, and high bilirubin. The features can be summarized as follow. Either systemic features like fever, chills, rigors, and loss of appetite, loss of weight, and jaundice. Abdominal features like pain, tenderness, localized GERD and rigidity, mass in the upper right abdomen, the tender, which is tender and soft liver, ascites, splenomegaly, abdominal wall edema, thoracic features like dry cough, right lower chest pain, right shoulder pain, pleural effusion, and intercostal tenderness, or features of complications like rupture, infection, septicemia, liver failure. Serological diagnosis includes indirect hemagglutination, gel diffusion precipitation, ELISA, immunoelectrophoresis, indirect immunofluorescence, and complement fixation. In diagnostic aspiration, recovery of the amoebic organisms occurs in 33 up to 90% of the aspirate. In plain X-ray, we may find the elevated right hemidiaphragm and evidence of basal atelectasis or pleural effusion. The arterial face of triphasic CT show a cystic lesion with a high attenuation of the surrounding normal liver parenchyma as shown by this arrow due to the hyperemia, and this gives rise to what's called double target sign. The course and sequelae of amoebic liver abscess. The abscess may rupture into the pleural cavity leading to emphysema. It may rupture into the lung and the bronchial tree leading to bronchopleural fistula, which lead to cough and expectoration of the ancophy sauce pus, and this may be a natural cure. It may rupture into the bare area of the liver leading to retroperitoneal abscess, may rupture into the peritoneal cavity leading to peritonitis, or may rupture into the intestine, or even may rupture to the skin leading to amoebiasis cutis. The most dangerous complication is the rupture into the pericardial cavity leading to cardiac tamponade, and this condition has a very high mortality reaching up to 30%, and this requires emergency thoracotomy and pericardial decompression. Septicemia and liver failure can occur in patients with amoebic liver abscess on top of cirrhosis. The previously mentioned complications can be summarized in this figure. The treatment of amoebic liver abscess usually starts with antibiotics in the form of imidazole antibiotics or metronidazole in a dose of 800 milligrams every 8 hours for a period of 7 to 10 days. It is better to give these drugs by intravenous route. Immetine, hydroimmetine, and the chloroquine may be used. The therapeutic aspiration is done under ultrasonic guidance. If the complaint persists for more than 72 hours, or when the drug is contraindicated, as in cases of pregnant patients. The aspiration is done by wide-bore spinal needle under local anesthesia. The site of aspiration depends on the site of the abscess. If abscess is anterior, the needle is introduced below the costal margin. and if posterior, it is inserted in the 10th intercostal space posteriorly. A few days later, ultrasonic examination is repeated, and if the abscess cavity has recollected or is more than 5 cm, aspiration may be repeated. Percutaneous drainage by catheter is indicated if the abscess fails to respond to conservative management more than 3 days, or when the abscess erode the neighboring viscus, or in patients with septicemia. It means secondary infection. But this has many complications like pulmonary, peritoneal, and pericardial complications. Indications for surgery. If the abscess cavity refills after repeated aspiration, if the abscess cavity contains thick contents, in multiloculated abscess, in multiple abscesses, in cases of ruptured abscess, in cases of left lobe abscess because the danger of rupture into the pericardium, in caudate lobe abscesses. Thank you.